Hi there, our highly valued, treasured and esteemed viewers and listeners, and welcome back to your channel of choice. This video I am about to present was compiled by Dr. Nath Arawa, a clinical pharmacist by training and profession who is the founder of Progressive Pharmacotherapy Consultants, the premier virtual clinical pharmacy institute for capacity building for healthcare workers. The Virtual Clinical Pharmacy Institute with a difference, where patient safety, medication therapy management and optimal clinical outcomes are very crucial and non-negotiable to us. Here we seek to remain your premier source of crucial tips for high-impact pharmacotherapy services. So, on behalf of the Institute, I humbly urge you all to sit back and spare me part of your very precious time to share with you very useful tips which may prove very, very handy in your line of duty. I now welcome you all to part 330 of our pharmacotherapy series, which majors in diabetes mellitus. The first question relates to patient SLH from part 329 of this pharmacotherapy series. What should the goals of therapy be for SLH and other patients with type 2 diabetes mellitus? Which biochemical indices should be monitored? The beginning of this chapter discussed general goals of therapy for all people with diabetes, which include eliminating acute symptoms of hyperglycemia, avoiding hypoglycemia, reducing cardiovascular risk factors, and preventing or slowing the progression of both microvascular and macrovascular diabetic complications. The ADA recommends that otherwise healthy patients with type 2 diabetes mellitus strive to achieve the same biochemical goals as those recommended for people with type 1 diabetes mellitus. When determining treatment goals for SLH and others with type 2 diabetes mellitus, the same individual characteristics should be considered as for type 1 diabetes mellitus, such as the patient's capacity to understand and carry out the treatment regimen and the patient's risk for severe hypoglycemia. Given the data from the ACCORD, ADVANCE and VADT trials, patients with type 2 diabetes mellitus and cardiovascular disease or multiple cardiovascular disease risk factors should be carefully assessed when determining the glycemic goals. For example, less aggressive A1C goals should be considered for patients with advanced age and short life expectancy, longer duration of diabetes mellitus, more than 10 years, advanced microvascular complications, or comorbid conditions such as significant cerebrovascular or coronary artery disease because of the serious consequences related to hypoglycemia. Therefore, glycemic goals for patients with type 2 diabetes mellitus must be individualized. Emphasis should be placed on assessment of all cardiovascular risk factors, including hypertension, tobacco use, dyslipidemia, and family history. As presented earlier in the relationship of glycemic control to microvascular and macrovascular disease section, the UKPDS was a landmark study in patients with type 2 diabetes mellitus that conclusively demonstrated that improved blood glucose control reduces the risk of developing retinopathy, nephropathy, and, potentially, neuropathy. The 10-year follow-up study demonstrated that these outcomes persist even though the conventional group achieved similar glycemic control with time, an overall relative risk reduction in microvascular complications 24% in the sulfonylurea or insulin-treated group compared with patients who initially received conventional therapy was seen. The exciting finding was that reductions in macrovascular complications emerged with time, with significant reductions in myocardial infarction, that is 15%, and death of any cause, that is 13%, in patients initially intensively treated with sulfonylurea or insulin. Metformin appeared to be of particular benefit, with even greater reductions in myocardial infarction and death of any cause, 33% and 27%, respectively. An additional finding of the UKPDS was that aggressive control of BP also significantly reduced microvascular complications, strokes, diabetes-related deaths, heart failure, and vision loss. During the 10-year follow-up study, these benefits diminished with time as the BP difference between the two groups was lost, i.e., BP increased in the tight control group and decreased in the conventional group. These findings stress the importance of maintaining good BP control to reduce the risk of long-term complications. Because SLH is relatively young and has no symptoms of microvascular disease or neuropathy, every effort should be made to normalize her glucose concentrations to prevent these complications. Furthermore, a lipid panel should be ordered, and steps should be taken to achieve normal LDL cholesterol, HDL cholesterol, and triglyceride levels. Often, triglyceride levels improve as blood glucose concentrations decline and the metabolic response to insulin improves. Biochemical indices that should be followed to monitor SLH's response to therapy include fasting, postprandial, and preprandial blood glucose concentrations, A1C values, and fasting triglyceride levels, as well as LDL cholesterol and HDL cholesterol concentrations. Based on ADA guidelines, initial metabolic goals for SLH should be an A1C value of less than 7%, and fasting plasma glucose of 80 to 130 mg per deciliter and postprandial glucose concentrations less than 180 mg per deciliter. The next question reads, how should SLH be managed initially? Initial therapy of type 2 diabetes mellitus is aimed at lifestyle changes that will minimize insulin resistance and risk for cardiovascular disease. In SLH's case and in the case of other overweight BMI 25.0 to 29.9 kg per meter squared or obese BMI equal to or more than 30.0 kg meter squared type 2 diabetes mellitus individuals, this includes a lower calorie, low fat, low cholesterol diet, regular exercise, smoking cessation, and aggressive management of dyslipidemia and hypertension. Because central obesity is associated with increased insulin resistance, SLH should be strongly encouraged to decrease her caloric intake, start exercising, and lose weight. Simple changes in her diet, such as cutting out juice and regular soda, and physical activity level can have a large impact on her glucose control. Self-monitoring of blood glucose monitoring should be encouraged, and education that addresses the serious nature of diabetes mellitus and its long-term consequences also should begin. This is discussed in the previous sections, medical nutrition therapy and physical activity, under treatment. Let's discuss initial pharmacologic therapy with metformin. The ADA recommends that most patients diagnosed with type 2 diabetes mellitus begin therapy with lifestyle modifications, including those mentioned above. In addition, most patients should begin monotherapy with metformin upon diagnosis. If metformin is contraindicated or poorly tolerated, agent approved for monotherapy may be used. The selection of alternative agents will be discussed later in this chapter. Although the UKPDS demonstrated that intensive therapy with sulfonylureas, metformin, and insulin reduces glucose with equal effectiveness, thiazolidine diones were not studied. Metformin is favored as a first-choice agent in type 2 diabetes mellitus, particularly in overweight patients. This is because metformin lowers blood glucose by decreasing hepatic glucose output and insulin resistance, indirectly, without causing weight gain or hypoglycemia. Metformin also has beneficial effects on plasma lipid concentrations as well due to a reduction in LDL as well as fatty acids. Another reason for metformin being a first choice for initial therapy is not only its proven benefit to reduce risk of microvascular complications, but also macrovascular disease and mortality. Furthermore, in an observational study of patients with type 2 diabetes mellitus, and established coronary artery disease, cerebrovascular disease, or peripheral arterial disease, metformin use was associated with a significant reduction in all-cause mortality, 22%, after only 2 years of follow-up. Metformin is also emerging as a therapy that may reduce cancer risk, possibly attributable to its activation of AMPK, which can suppress tumor formation. Data so far have been in animal models and observational studies in humans. The drawback to immediate-release metformin is that it requires multiple daily dosing, and its dose also must be titrated to minimize GI effects. After the dose is established, it is possible to use a long-acting product that can be dosed once daily. Alternatively, extended-release metformin may be initiated at a dose of 500 mg daily and titrated upward as tolerated. Renal function tests should be evaluated before the drug is initiated. SLH does not have any contraindications, renal or hepatic dysfunction, cardiorespiratory disease, binge alcohol use, to the use of metformin that could predispose her to its most significant side effect, lactic acidosis. Because SLH exhibits the typical features of insulin resistance syndrome and has no contraindications for its use, she should be started on metformin. Her A1C goal of less than 7% will require an additional 1.3% lowering in her A1C, which can be achieved with metformin. However, any changes in her lifestyle will further help lower her A1C. SLH should take metformin 500 mg twice daily with food. The next question reads, SLH is started on metformin 500 mg twice daily with food and instructed to increase her dosage to 500 mg every morning and 1000 mg every evening after 1 week. 3 days after starting metformin, she phones the clinic complaining of nausea and diarrhea. She admits to taking her doses on an empty stomach. How should SLH's symptoms be addressed? GI disturbances such as diarrhea, bloating, anorexia, abdominal discomfort, nausea, and metallic taste often dissipate with time and can be minimized by initiating metformin in a single 500 or 850 mg dose at breakfast or with the patient's largest meal of the day. Consistently taking metformin with food significantly minimizes the GI side effects. The dosage should be slowly increased, e.g., 500 mg per day every 2 weeks, until the appropriate clinical effect is achieved or the patient is taking the maximal dose, 1000 mg twice daily or 850 mg thrice daily. Therefore, SLH's metformin dose should be reduced to 500 mg daily with her largest meal, and she should be titrated more slowly during a period of several weeks. Metformin is typically dosed 2 to 3 times daily. The long-acting formulation is dosed once daily with dinner. Twice daily dosing for adherence purposes is preferred if a patient can tolerate a 1000 mg dose or once daily with the extended-release formulation. If she continues to experience GI symptoms, an alternative approach is to use the extended-release formulation. Small studies have demonstrated improved tolerability with the extended-release tablets versus the immediate-release dosage form. The drawback to these tablets is their very large size. Also, patients may complain that metformin has a fishy odor which seems to be more apparent with certain generic formulations. If this is significant enough to cause a patient to stop taking it, the extended-release formulation can be tried, which may be more tolerable. The next question reads, how should metformin therapy be monitored in SLH? As is standard with other agents, SLH should be encouraged to perform self-monitoring of blood glucose and have an A1C test performed quarterly until she achieves consistent values less than 7%. Additional evidence of the therapeutic benefits of metformin may include an improved lipid profile and some weight loss. Initially, it is important to monitor GI problems, and although lactic acidosis is unlikely, SLH should be warned to bring to the attention of her physician any sudden symptoms of shortness of breath, weakness, and malaise. A baseline serum creatinine, LFTs, and complete blood count should be obtained for SLH and repeated yearly. Metformin can reduce vitamin B12 absorption, and it is associated with reductions in vitamin B12 levels 19% after 4 years of use in one study, and actual deficiency. Therefore, monitoring of vitamin B12 levels every 2 to 3 years should be considered with long-term use. The next question reads, SLH is interested in learning how to perform blood glucose testing. What are the advantages and disadvantages of self-monitoring of blood glucose tests? When and how often should SLH be instructed to test her blood glucose concentrations? Self-monitoring of blood glucose is an important self-management tool for patients such as SLH to assess the efficacy of therapy and guide adjustments in nutrition, exercise, and medications. Disadvantages include cost of testing, inadequate understanding by both healthcare providers and patients regarding the benefits and proper use of self-monitoring of blood glucose results, patients' psychological and minor physical discomfort associated with obtaining a blood sample, and the inconvenience of testing. However, with the current advances in meter technology and proper patient education, most of these potential barriers can be overcome. The ADA states that self-monitoring of blood glucose may be a useful guide for patients with type 2 diabetes mellitus treated with medical nutrition therapy or non-insulin therapies, although there is insufficient evidence to determine optimal frequency of testing and demonstrate cost-effectiveness for these patients. Although one meta-analysis of self-monitoring of blood glucose effects in patients with type 2 diabetes mellitus not on insulin concluded the overall effect on A1C was a 0.4% reduction, others failed to show a benefit. Self-monitoring of blood glucose studies in patients with type 2 diabetes mellitus are often limited in that multiple interventions, such as education, diet, and medication adjustments, were used. However, a primary reason studies fail to show a benefit is that patients are not taught what to do with their blood glucose numbers, i.e., how to respond to a low blood glucose reading. The blood glucose values are solely used by the providers to make adjustments to their therapy. Self-monitoring of blood glucose should be considered for most patients with type 2 diabetes mellitus, particularly those who are learning to adjust their carbohydrate intake and portion sizes and want to measure how well medications and lifestyle changes are working to improve the glucose control. Although not always cost-effective, testing 4 times daily before meals and at bedtime for 1 week is useful, so that the patient can observe his or her glucose profiles. Later, once the desired A1C has been achieved, blood glucose can be tested less frequently. Testing times should vary throughout the day so that fasting as well as postprandial and bedtime values can be assessed. As emphasized by the ADA, intensive patient education regarding testing technique and interpretation are vital to the cost-effective use of this monitoring tool. The patient must learn how to respond to his or her glucose profile and institute lifestyle changes that can have a favorable effect. The next question reads, SLH was quite motivated to improve her glucose control because her grandmother lost a leg to diabetes and her aunt is undergoing dialysis because her kidneys have failed. She is taking metformin 1000 mg orally twice daily and tolerating it reasonably well. She occasionally gets some stomach discomfort, but states she is fine with it. She is proud that she remembers to take the metformin every day as instructed. She met with a dietitian who suggested an 1,800 calorie diet and 45-minute walks 3 times weekly. After 3 months, SLH lost 6 pounds. SLH stopped drinking regular sodas and juices, but eats either breads or 2 large tortillas at each meal. She admits to eating only small amounts of greens and vegetables. She has not been able to implement her walks 3 times weekly, more often she only walks once a week. Although her fasting plasma glucose fell to 130 mg per deciliter, a majority of her postprandial blood glucose levels were more than 180 mg per deciliter. Her A1C is 7.4%, and fasting triglyceride levels are now 260 mg per deciliter. How should her therapy be adjusted? What factors should be considered when deciding on the next steps for pharmacologic therapy? SLH's A1C has improved by 0.9%. However, she has not fully instituted lifestyle interventions. Although she has cut out juices and regular sodas, she can still further improve her diet and lower her postprandial blood glucose to less than 180 mg per deciliter by reducing her carbohydrate intake, switching to whole grain breads, and increasing her vegetable intake. She also can increase her physical activity to at least 3 times weekly. Although the A1C is not less than 7%, a reasonable approach would be to continue metformin at 1000 mg orally twice daily and reinforce lifestyle changes at this point before modifying her pharmacologic therapy. The amount of A1C lowering in response to adding an antidiabetic agent appears to depend on the baseline glycemic level. A meta-regression analysis of 61 clinical trials evaluated the efficacy of the 5 classes of oral agents: sulfonylureas, glanides, metformin, thiazolidine-diones, and alpha-glucosidase inhibitors. Significant correlations were found between the baseline A1C and fasting plasma glucose, and their mean decreases as a result of these agents. Greater reductions in A1C and fasting plasma glucose were observed in groups with higher baseline levels. In addition, a meta-analysis of oral agents found that every 1% higher baseline A1C level predicted a 0.5% greater reduction in the A1C after 6 months of therapy. Overall, on initiation of non-insulin monotherapy, the A1C will typically lower by approximately 1% to 1.25%. If SLH is not able to reach an A1C of less than 7% with lifestyle interventions, the next step for her would be to add a second antidiabetic agent. Selecting an antidiabetic agent to treat type 2 diabetes mellitus has become more complex because new agents with unique mechanisms of action have been introduced into the market. Several considerations should be taken into account when choosing initial oral therapy for patients with type 2 diabetes mellitus. As with all therapeutic decisions, clinicians should also blend their knowledge of the drug, e.g., its efficacy, safety, hypoglycemic risk, weight gain, other side effects, route of administration, and cost, hospital formulary, with the unique characteristics of the patient, e.g., level of glycemic control, organ function, other concurrent diseases and medications, ability to adhere to complex medication regimens, health insurance coverage, when making a choice of drug products. The current A1C level and reduction required to reach the A1C goal is a key consideration. It is also important to remember that studies report the glucose-lowering effects of antidiabetic agents by their means. Some patients respond more and some respond less than the mean. The AACE guidelines recommend consideration of initiating insulin therapy, most often basal insulin, if the A1C is more than 9% with symptoms of hyperglycemia. The ADA guidelines recommend choosing based on patient's level of glycemia and if they are symptomatic. It is an option for dual therapy in all patients, especially if A1C greater than 9%, but should be strongly considered with an A1C above 10%. Practitioners should attempt to avoid unnecessarily complex therapy that may confuse the patient, increase drug costs, and complicate the clinician's ability to assess each medication's contribution to the overall therapeutic outcome. The ADA recommends initial therapy with lifestyle changes and metformin monotherapy. If the patient cannot tolerate metformin, any other agent approved for monotherapy may be used. These agents include sulfonylureas, thiazolidine diones, dipeptidyl peptidase 4 inhibitors, sodium glucose cotransporter 2 inhibitors, glucagon-like peptide 1 receptor agonists, and insulin. Selection of appropriate agents will be discussed later in this chapter. If after 3 months of monotherapy the patient has not achieved the glycemic targets, a second agent may be added. If the patient still has not achieved the glycemic targets after 3 months of dual therapy, a third agent may be added. If glycemic targets still have not been reached after 3 months of triple therapy, different drug classes should be tried and a basal bolus insulin approach may be considered. So there you have it, our highly esteemed viewers and listeners. That brings us to the end of this video. If it benefited you in any way, kindly remember to give it a thumbs up, to like it and to share it widely with your peers. Please leave your comments at the bottom. And if you haven't yet done so, I humbly urge you to subscribe to our YouTube channel. I would like to promise you all that the very, very best is yet to come. Thank you very much for viewing this video. On behalf of our senior colleague, Dr. Nath Arawa, I sincerely appreciate your partnership, continued support and kind collaboration. We look forward to interacting with you in the next video, which will be part 331.